Meeting to order. I'd like us to pause to seek guidance, please. Okay, so I'm going to read the mission statement. To provide, promote, or facilitate municipal services that meet the community needs while preserving, supporting, and enhancing quality of life for all. The next is the approval of the agenda. Is there any additions or deletions?
I move approval of the agenda as circulated.
I second it.
All in favor?
Aye.
Contrary minded, motion carried. Next, we have a presentation from Deborah Boudreau on aging and continuing care. Could I have someone willing for her to come forward? Is there a seconder?
I'll second.
All in favor?
Aye.
Contrary minded? Come forward, please.
Thank you, Warden Gregory, and thank you to everyone for the invitation. Some of you will have heard this because you also sit on the Tybee Terrace board, and I went to a meeting one day and came back with a couple of set of slides and thought that the board at Tybee would be interested in the information. And from there it went forward, and I believe Warden Gregory felt that it was pertinent to the work and the decisions and the activities that are happening here. And so hopefully I'll do justice to the two people who put the presentations together. I did not, so I will not take credit for them. The first one is pulled together by the Health Association of Nova Scotia, to which the Tybee Terrace is a member. Catherine Yule does an environmental scan of both Canadian and international literature 4 times a year. And what she focused on this last quarter was on aging and continuing care. So I'll speak to her slides. As with most things, there's ambiguity in it. So one slide may not support the next one, but that's how life is. That is the information that's out there. So take it as it's worth to you in your context. The other slides that I'll go quickly over is they were put together by the Department of Health and Wellness, the Continuing Care Branch. Ruby Knowles is the Executive Director, and she gave us a profile of the continuing care clients in Nova Scotia. So I'll go into the clients and the caregivers in more detail. So to start off, just take a moment. I'm sorry, we're bombarded with aging boomers. Come back in about 20 years. So there's this perception out there that our senior population is taking over in terms of accessing healthcare services. And so it's not leaving much available to others who are less senior. But the reality may not be exactly that. I might be aging 1 year every 365 days, but it doesn't mean that the population is aging to that same degree. So this perception of a gray tsunami that's overtaking the healthcare system may not be as severe as what was thought of back in 2000, 10 years ago even. So the population is not aging as quickly as perceived, and the aging accounts for a relatively small portion of the increase in the healthcare spending, because that's what we see that makes headlines. All these seniors are accessing the emergency room, they're filling the hospital beds. Well, there's actually less than 1% annually in the growth for healthcare spending that can be attributed to the senior population using services. So it's a little bit of a different message than what we may have been hearing in the past. The population contribution related to the growth in spending for Canada is 0.8, for Nova Scotia is 0.1, and you, I'm sure, already know that is because the population, the aging population in Nova Scotia is slightly higher than the national average. And we see that on this slide. So really, what is then driving the healthcare costs if it's not just utilization by seniors? Well, we've all heard in the news lately, wage settlements. We've seen the NSNU settle their contract in acute care and continuing care. We've seen NSGU also settle their contracts, mainly in Halifax, but they also have an impact around the province. CUPE as well. Continuing care is next on the block, so we'll see that happen probably in the next nine months. So the wage increases are having a huge effect on driving the healthcare costs, as do technological advancements. I mean, look, I have a wireless keyboard. You find them in hospitals and facilities as well. You know, you see the nurses now with the handheld PDI or personal data devices. It's all about healthcare. You know, we get referred to MRIs now and CAT scans, not so much X-rays. X-ray machines are breaking down. They're not getting replaced with X-ray machines. They're getting replaced with other things. Those have huge costs. Utilization is only one factor. So we know that in Nova Scotia, 16% of our population is senior, as defined 65 and over. 14% in Canada, so we're a little more, we're showing our age a little bit more than Canada. Senior use approximately 40% of hospital services, and the government spending accounts for about 45% of programming going towards seniors. It is known that seniors do spend a longer time in hospital when they get admitted, up to 50% longer. We also know that seniors tend to have a lot of prescription pills that they're on, 10 plus. 1 in 4 seniors have 10 plus medications that they're taking. 2/3 of them have 5 plus medication. Also, seniors account for 1 in every 11 emergency room visits. So you can't deny that they are impacting the system, but they're not the sole reason. So what can we do about some of those drivers? Well, we need to look at, do those seniors really need those 10 meds? Are those emergency rooms truly emergencies? And you know, the warden was at the DHA's AGM the other day and asked the question, can't we have nurse practitioners staff the emergency room? The answer was clear, no, you can't. But is that where you really need them? If it's not really an emergency, then where else can we access those services appropriately staffed by the nurse practitioner through some kind of primary care clinic or some other means that is less expensive than the true emergency room? Do the services need to be delivered in a hospital? We've tended to see the hospital as the wellness model, that the hospitals are the illness model. Where else can you put the services so that they're more accessible and at less of a cost than what you find in the hospital? There's also some indirect costs. Those 10 meds, they probably have drug interactions. They probably have side effects that require other meds to be prescribed. And as soon as you get admitted into a hospital, what often happens? You contract an infection. And a senior, frail, elderly person is more susceptible to getting that infection than a well adult or a child, even a well young adult. This is a quote from the CEO of a long-term care facility. Healthcare spending is a consequence of choices policymakers and leaders of the healthcare system make. It's not just because we have a senior population or a population that's aging. We're making the decisions as senior leaders, as healthcare leaders, as municipal leaders. We're the ones making the decisions where those dollars are going. So what does that mean for the future in terms of supply and demand? It is a generally accepted fact, or an assumption, one could say, that with the aging population, there is an increasing demand for service that will eventually outweigh the declining supply of caregivers. So let's look at the demand a little bit closer. It's estimated that the number of seniors who need assistance will double in the next 30 years. And the values and the beliefs of those baby boomers are changing. They are different than our grandparents today and their grandparents that we're serving today. The people who are becoming older are much more educated. They very much value their autonomy. They do not want to be a burden on their family. You know, I will look after my aging parents mentality is maybe not there with the baby boomers that is coming on. And they're also accustomed, they grew up with a public health care system. So again, if you look at the older generation right now, they didn't grow up with that system. They didn't expect that these things were going to be free, but we expect them to be free. We know that when we go to hospital and then we call up for a service, we're paying taxes already. We don't want to have to pay for that twice. So these factors suggest that the next generation of seniors will be more likely to access formal services because they're used to that. Their health status potentially will be different. Their longevity potentially will be shorter than the population that is aged already. There's a lot of more chronic illness today. We've kind of hit that peak from an average life expectancy age of around 82 or so. At some point we're going to see that lowering again. We hear the obesity rate in kids and all of those other factors that are happening. That's going to eventually have an impact on that life expectancy. We also have chronic disease trajectories, a whole pile of medical innovations that are out there happening to deal with chronic illnesses and more cosmetic things. So looking at the supply, if that is the demand, then what will the supply look like? Well, we know that we can probably expect an overall decline in family caregivers. And the reason is that by the year 2031, approximately 25% of elderly women will not have any surviving children. Divorce rates are higher. Women are in the workforce now, more so than in the past, so they're not available to be a caregiver. They're having less kids. You know, the families of 6, 7, 12 kids don't exist anymore. There might be 1 or 2, 3 at most, and so there's not a lot of kids around to take care of the elderly parents anymore. And also we've seen the proximity between the adult children and the elderly parents increase. Everybody's moving out west. You know, they're not living next door anymore. They're not available to be the caregiver anymore. Now this is a little scary. So given that last slide and the declining availability of caregivers, in 2007, the market value contribution of family caregivers, this is the informal unpaid caregiver, was somewhere between $24 and $31 billion. So without that, you got a crumbling healthcare system. There's no way that the tax base can support that amount of dollars increased in the healthcare system. They truly form the backbone of the healthcare system. And the current caregiving policy really do not support that whole unpaid workforce. It's based on the assumption that the family will step in and take on the caregiving responsibilities. And we know that that's on the decline, certainly not on the rise. Now these might be a little hard to read. Nova Scotia is that turquoise line. So the first graph on the top left is looking at the average hours of home care service provided in a week according to the senior's level of need. So as the level of need on the lower axis increases, you can see that turquoise line doesn't increase very much. It pretty much stays the same. So even with more need, more service is not being provided. The bottom slide looks at the average hours of the informal, the family caregiver support in a week related to that person's need. So again, if I may, this axis down here is a reflection of the acuity of need, and you can see the turquoise line, more family support is offered, as we would expect, once the care needs increase. However, what tends to happen is the acuity needs increase, the demand on the families increase, but the demands offered or the support offered by the system doesn't increase. And so when you ask the question to those informal, unpaid family caregivers, are they stressed? They answer back, the more the person requires care, the higher stress they feel. And so this graph is just that percentage of the seniors with distressed family caregivers related to the senior's level of need. So it's a little bit of a grim picture. So what is available to that informal caregiver in terms of relief for their stress? Well, there's a family tax credit, family caregiver tax credit, that's valued at about $300 a year. It's not based on the need of the individual receiving the service, it's just a flat rate. Bear in mind, you need to be working in order to even get this tax credit. And if you're providing services to somebody, you may not be working. You may have quit your job, which is what the graph on the bottom shows, is that only 57% of caregivers are actually employed. So the remaining aren't even eligible for this tax credit. And of those 57, 13% of them report that caregiving has impacted their work. And so the bottom graph is what that impact looks like. So at the very right of the screen, 52% of them reduced or modified their hours in order to support caregiving. The next one, 32% of them used vacation or sick leave to provide that care. The other examples is they took unpaid leave, they stopped or they retired. 10% actually stopped working or retired. Some actually increased their hours of work or worked more, maybe to pay for services for somebody else. 6% turned down a job or a job promotion. And 3% took a leave or decided to leave and take a less demanding job. So there's huge impacts on the informal caregivers. So what does that mean for us as the policymakers and the deliverers of care? It means that we need to keep providing current demand needs while trying to plan for these future needs that may look very different. We know that with the declining support of informal caregivers, we'll need to have some kind of more formal, comprehensive, long-term home care program. The quote that follows, most of our current policies put a primary focus on just the short-term hospital replacement home care, when in large part it's often the non-professional supportive care that allows people to continue to function independently and therefore live at home. So it's the things like snow removal, mowing the grass, getting the mail, housekeeping, making meals, doing errands, grocery shopping, the things that aren't really funded in the system that exists today. What does it mean for nursing homes? Potentially earlier admissions, because there will not be that informal caregiver to take care of that person at home for longer. Or it may also mean a higher acuity of clients once they come into the system. So I'm going to leave that one and go get this one. And this one has some slideshow. This one has some details. Oh, I might need some technical support. This one, I don't want to do that.
Your left.
Oh, here, right here.
Your left, right click, or right click is still on.
No, I like it.
Here, on this one. Oops, sorry. Over to your camera thing through there.
Thank you. All right, so this is a little bit more local information on the clients, who they are, and the caregivers. And so this was some data on the home care program and the long-term care program. This comes out of the Department of Health and Wellness, the continuing care branch. Again, it's not my information, I'm just the medium delivering it. I certainly don't want to take credit for it. So in 2010-2011, there were 12,369 active clients on the chronic home care program in Nova Scotia. On January 4th, this is a moment in time snapshot, on January 4th, 2012, so not all that long ago, there were 1,313 clients waiting for their initial placement in a long-term care nursing facility or a residential care facility. If you break down that number, 640 of them were waiting in the community receiving home care services, so they make part of that 12,000. 451 of them were waiting in the community without any publicly funding home care services. So you wonder, well, maybe they've got private caregivers, but we'll see that a little bit later. And 221 of them were in a hospital bed. So of the hospital beds in the province, 221 of them were filled with people waiting to access long-term care. This data comes from the RAI minimum data set that the province collects.
I have a question. Is priority given to the ones in the hospital, or is it just case-by-case basis?
It depends. It's not an easy answer. The hospitals can get variances. So when the hospital gets backlogged, which usually means the outpatient departments are backlogged, they're waiting in the hallways and whatnot, there's no bed to admit them to, then the DHAs can apply for a variance to the policy. Otherwise, people are put on the wait list based on the date that their assessment was complete. So not even I need more care than you, so I get...
It's just whoever's got the people who are organized enough to help them get in, or they themselves have the skills to get themselves in.
It's by chronological order.
Mm.
Yeah.
Mm.
And there is method to that madness. It really isn't that mad, actually, because what can happen is if the hospital is always the priority, then people quickly learn in order to get into a long-term care bed, you need to first get into a hospital bed, which is not necessarily a good use of those resources. So there's quite a bit of thought that's been put in that policy. It's certainly not perfect, but it is what it is. So of those home care clients, 64% of them are 75 years and older. So certainly the majority of the home care services go to a senior population. When you include the people 65 and older, that number jumps to 82%. Only 18% of them are younger than 65. And almost half of them, 45%, live alone. When you look at those
100 people on the wait list for long-term care, 83% of them are 65 and older, and 54% of them live alone. So there's really not that much big of a difference between age, whether you're in home care or waiting for placement, and whether or not you're living alone. They're relatively close to one another. The vast majority, 2/3, are female, and only 1/3 are male. Men die sooner, and female spouses take care of the men more than men take care of the female.
Well, they quite often are younger too.
Remember I said there was a number, there was about 400 people on the wait list that weren't accessing publicly funded home care services. And so the initial question in looking at that was, well, maybe they're getting private services? Probably not, because 2/3 of them are in what is considered the lowest income category. And by that, it means that how that's assessed, category A, is people who are only getting old age security and guaranteed income supplement. So they're not getting a CPP, they're not getting any other benefit. So, minimum income they're getting. 73% of clients on the waiting list for long-term care were not receiving publicly funded home care services, and they were in that category of the lowest income. So they can't afford to hire somebody privately, so they're not getting any services. When you start to look at what is actually being delivered in direct service hours in home care, the number of hours or the volume of service. Remember those two graphs with that little line? It was much steeper for informal hours of care, pretty much stable regardless of acuity for paid care. Well, almost half, 45% of all home care clients were only authorized 1 to 19 hours of home support services a month. Not a week, a month. And only 11% of them were authorized for 80 or more hours in a month, which works out to be about 20 hours a week. So when you consider over a 7-day period how many hours there are, there's only 20 hours of those on average being offered by a home care worker. The rest is all covered by the informal caregiver or the person being alone and not getting any care. So we have a long way to go. Almost all the clients, even though they said about half of them were living alone, they all identified a caregiver, over 90% of them. So that caregiver isn't necessarily home-based in living in the same home, but there's somebody in the community, whether it's a neighbor, somebody down the street, somebody in the next community, who the client is saying, they are my caregiver. Of those 90% who have a caregiver, those caregivers, 20% of them indicated some form of caregiver distress. Of the informal support of the informal caregivers providing support of 25 plus hours a week, that covered about 17% of the home care clients. Those waiting for long-term care, who were also receiving home care, were also getting 25 plus hours of informal support, accounted for 74% of the people on the wait list. And 24% of the people on the wait list weren't getting any home care, but they were getting 25 plus hours from caregivers, informal caregivers. And this, I'll end with this slide. This is, it goes to the question that came forward related to how do you get placed on the wait list? Is it by need or acuity or something else? The first column, all HC, so the 12,000 people who are receiving home care services, that first number is the percentage of people who are assessed to be either independent or needing limited supervision. So that makes sense. If the person is still living at home on their own, there's a pretty good chance that they need to be somewhat self-sufficient in terms of their activities of daily living. But when you look at that line across the top to the people waiting for long-term care, again, it's quite as expected. That degree of independence starts to decrease as soon as they go on the wait list for long-term care, and it's at its lowest when they're in hospital. They're in hospital, they're not doing these services for themselves. The same with instrumental activities of daily living. That's a measure of a person's ability to cook and clean and do their banking and all of those things. Again, home care clients, about 74% of them are saying that they have great difficulty in doing these things. So, shoveling, taking care of the home, those things. 95% of them who are in hospital waiting for long-term care. That makes sense. The third column is a measure of cognitive capability, a person's ability to reason and think and judge. And so,
Does that mean 77%?
have a mild or an intact cognitive ability, which makes sense, right? Because they're still living at home, so one would expect that. But again, as they go on the wait list and they're receiving or not receiving home care, or they're actually in hospital, you would expect that to decrease. In other words, their cognitive capacity is worse. It becomes more severe. And the last is a measure of overall functional ability, the MAPLE score. And so those that would rank as a very high or at a very high risk, very high acuity, it makes sense that the higher numbers are the ones in hospital waiting for care. So I will leave you with that information.
Is there any questions? Deputy Warden?
I have a few. First, can we have a copy of that presentation?
I emailed it to Linda earlier today.
Okay, good. A couple things. Has the caregiver's tax credit ever been increased in the last while? Do you
I
know?
do not know the answer to that question.
Okay. One model that I think really has to be looked at is a lot of seniors like to stay in their own home as long as they can. And based on what you said in the presentation, where it's going to be harder for caregivers to provide services to seniors, is there any thought or has been any discussion on whether or not there could be a program implemented where you could match seniors, where you could have maybe 2 or 3 seniors living under the same roof and they could help each another? I'm not saying that they'd still maybe have to have home care, but it would maybe make it more affordable for a senior to stay in a home. And I'd like to see maybe something done in regards to research whether or not that could be a possibility, because we do have some of the highest levels of seniors in Canada, in Nova Scotia, per capita. And they've got to come up with other models. Like you said earlier, we can't afford to have everybody get the full package. We just don't have the resources for it if the caregivers weren't going to be there. So, and I had something else here too. I've always thought that the old Skyview building should have been turned into an assisted living property. And do you know if there's any programs in this province? I know when they opened up the new Skyview, you didn't even get one new bed. And yet we've got an aging population. and yet they didn't contribute no new beds to this community. And I don't understand that rationale. And you know, even if it had gone up 10%, it would have shown at least some foresight that, you know, at least we're trying to do something. And to add 10 more beds to a facility like that, I wouldn't have thought would have been an extreme measure. But I really am saddened to see that the old building is not going to get used for an assisted living facility, which I think that maybe could have been renovated. I don't know enough about the old building, but it's going to be a shame to see that tore down when there potentially could have been some useful life left in it. So.
To your first point, there are some innovative models, particularly in Europe, on communities of aging. To the point where physical communities are being built with the intent that people will live and die in their home. And so the homes are built with accessibility in mind. The governments are supporting the services to go into those communities. And as we all know, when one care coordinator or one continuing care assistant is driving from point A to B to C to D to see X number of clients a day, there is time spent wasted traveling. And so if you can put everybody in the same area and put one person there, that person's time is used a lot more efficiently. So those models certainly exist. There are a couple of little communities, even in Nova Scotia, that have tried to mimic as best as they could that model. I'm thinking, for example, Shore Inn Village down in on the South Shore, where they've built various models of homes and assisted living facilities, and then the nursing home is right next door, and so home care accesses those areas. So very much a partnership with private developers, as well as some government funding to support some of that. And there's a few other little communities like that around the province. Shanex is a good example. A private provider, they build apartment complexes, seniors complexes, assisted living. The Berkeleys is another one where they also are in the long-term care providing environment as well as the private side of things. As far as Tideview, as you all know, Tideview is a not-for-profit society, and our business is long-term care, and the board steers that decision. And so not that there wasn't a realization or an understanding that those services could be useful in Digby. Nobody came forward, no private developer came forward to purchase that building. Certainly Tideview didn't have the bucks to invest in renovating it. So at the end of the day, as you all know, the building is up for demolition, and there will be a prime piece of property there. Who knows, a developer might come along, and you know, the reality of what I heard, which is all through the grapevine, is no developer wanted it. It was more expensive to redevelop it than to just build new, right? Because you're tearing down walls and rebuilding them. So there was no viable proposal that came forward, and that's where we are left today.
That's fine, but now that once it gets tore down, couldn't they have a brand new assisted living complex put up there, like a P3 arrangement with the provincial government and with contractors or anybody that wanted to invest in it?
Anything's possible.
Because
Unfortunately,
I would think that there's a demand in the community for an assisted living unit, and that would take some pressure off of Tideview, and actually the hospital, because having to have people go in the hospital and wait, that's a huge burden to the taxpayers of this province, because the cost per day for a bed in the hospital is quite high. And if there's any other models that could come out and provide a cheaper cost to provide that same service, they should be really seriously looking at that. Anyway.
The government has not yet entertained P3 agreements. And up to today, they've been very clear that they aren't in the building, in the provision of assisted living. They do home care, they do long-term care, they don't do any other form of service provision. And so it really would be up to the community to come together and find those partners who might have dollars to invest and some foresight and some creativity.
Well, there's one program that I don't know whether or not they could use this program for that type of a situation, and that's the CEDA, Community Economic Development Fund. Now, whether or not you could use the CEDA to build an assisted living complex, I don't know. But I'd like to see, and I know it's not your call or your responsibility, but it would be really nice to see government look at different options to provide those services, because I've attended 2 population forums over the last couple of years, and we're going to have some serious problems on our hands, and it's not that far away. So, and they've got to start thinking about what they're going to do now to address those issues. Anyway, thank you.
Councilor Tudor.
How do you get someone a home care worker specifically? Because on the islands, just everybody sort of keeps care of you. You know what I mean? Like I know several people that drop by one guy's house, none of them related, cleaned up, making sure they get people to the doctor and stuff like that. I don't know though of any healthcare home care workers down there. It's just we're sort of out of the loop. How would I go about something like that? Because we do have a very aging population. Like you said,
There is home care down there.
there is.
Yes.
So is it, how do you go about finding, getting someone? Is it through the social services?
No.
The Department of Health, and now actually the DHA, because the employees fall under the district health authorities. There's been a transition there. It's a single entry access system. It's a 1-800 number. If I can say it off the top of my head, 1-800 225-7225, I think. Make sure you look in the phone book before you give that number out. Look under continuing care services, and it's just a phone call, and it's you know, who is the person, what is the service that they need, where do they live, the intake process, and then a care coordinator will be sent out to actually do an assessment of that individual, and that's universal, whether it's for home care services or access to long-term care through a nursing home or a residential care facility. It's the same intake process, the same assessment process. And once that's done, if the person is eligible for services, then, for instance, home care services would be authorized and delivered in this area through the DB Clare Home Support Agency. If it's for home care, if it's for nursing in the home, the service provider is VON. And if it's long-term care, you can access any long-term care facility in the province locally. You know, Tideview's next door. There are others down the road as well.
All right, thank you very much.
Any other questions? Hearing none, I want to say thank you very much. We really appreciate you coming to. I just thought it was something that would be of interest to the whole council.
Thank you for the invite. Can I just hold my memories? Thanks again.
Thank you.
Thank you.